Good afternoon, ladies and gentlemen, and welcome to today's webinar. I would like to remind you that this conference is being recorded. At this time, all participants are in a listen-only mode. For those connected by telephone requiring operator assistance during the call, please press *0. Web participants requiring support should use the chat feature on your screen. I would now like to turn the meeting over to your moderator for today, Ms. Kay Phillips, Senior Director at Canadian Foundation for Healthcare Improvement. Please go ahead, Ms. Phillips.
Hi, welcome everyone, and good afternoon. This is our part 2 of our on-call series, Data Bootcamp, How to Get Your Data into Shape. I'm Kay Phillips, Senior Director here at Canadian Foundation for Healthcare Improvement, and I'm pleased to be your host today as we present the second session in this 3-part series, which will focus on enhancing data quality for improvement. Today we're pleased to have more than 100 lines on this call, so welcome, and if you haven't done so, please do introduce yourself. Now, as I introduce our guest speakers, I'd ask, as I mentioned, to take a moment to introduce yourselves in the chat box, who you are, where you're from, as well as any questions that you might have. Joining us today is Trevor Strone, who has nearly 2 decades of healthcare informatics and analytics development experience. In his current role at the Winnipeg Regional Health Authority Emergency Program, Trevor leads the development and implementation of informatics and analytic tools for use in healthcare quality and performance improvement initiatives. He's also assistant professor with the Department of Emergency Medicine, University of Manitoba, where he participates on clinical and operation research projects and lectures on topics related to data science, informatics, and quality improvement. Also with us is Melanie Rathgaber, a CFHI measurement coach and president of Merge Consulting. Melanie specializes in using data for quality improvement and has experience that spans a variety of healthcare sectors, including primary care, mental health, and acute care. Melanie led improvement and measurement initiatives at 2 provincial quality councils, including Saskatchewan and BC, and more recently switched her focus to mental health, where she works firsthand with staff and patients to measure and improve quality of care. We are also pleased to have our producers behind the scenes, Sheena Powell and Kelly Ripley, operating from our Ottawa studio today. Now, on today's call, we're going to continue our conversation from the first webinar in October, which focused on getting back to the basics when it comes to healthcare data for improvement. In today's webinar session, we're going to start by talking about strategies for enhancing the use of available data sources for improvement. We'll drill down into how to evaluate, improve, and achieve higher data quality, which in turn leads to better decision-making and performance improvement. And we'll introduce participants to effective ways to use data, including measuring the right things the right way, the way that data preparation and processing and disseminating data to stakeholders can be done. Now, we heard great feedback from those who attended the first session of this series, including the request to provide French versions of the presentation and materials. We're happy to let you know that all materials for this webinar series are now available in French and have been circulated out to participants in advance of the call. If you did not receive the slide deck or associated materials, do not worry. We will resend them after the webinar today as well. I'd like to now hand it over to Trevor, who's going to get us started on thinking about how to enhance data quality for improvement. Trevor?
All right, well, thank you very much for that great introduction. I'm happy to be here today covering part 2 of our data quality series of presentations. So we're going to start off this morning's or this afternoon's presentation, depending where you are, on looking at some of the causes of poor data quality. In the last webinar that we had in October, we touched on this. So if we were to do a quick review, I wanted to bring up this slide from the last webinar. And this slide really is here to remind us that there are many dimensions of data quality, that data quality isn't something that is purely black or white, right or wrong. If we look at one of the definitions of data quality that we spoke of last time, there was a quote from Joseph Duran, who's a well-known quality consultant, and his take on data quality is that data are of high quality if they are fit for use in their intended operational, decision-making, and other roles. He also we also wanted to impart the fact that we can't aim for data quality perfection. There's no such thing. We're never going to get perfect data. It's also not necessary to have perfect data. As our quotation from Joseph Duran says, we need to work to ensure that the data is fit for our intended purpose. Also, if we spend a lot of time trying to aim for data quality perfection, we're not going to start anything at all. And so while we're chasing our tails trying to achieve high data quality or perfect data quality, we're going to be missing the boat in terms of achieving, important healthcare improvement initiatives. I'm not going to go through these all in detail one by one, but it's really important to remember that data quality manifests itself in many ways, and some of the ways that we look at data quality include accuracy, how well the information reflects the actual reality it's intended to measure, the timeliness of the data, comparability, which is the extent to which the data is consistent over time. Usability is a key aspect that we're going to talk a little bit about in more detail today, but that's how easy the data is to access, use, and understand. Related to usability, actually, is the relevance of the data, how well the data meets the current and potential future quality improvement requirements of the organization. Completeness is basically a measure of how much of all the data is available to decision makers. Conformity dimension discusses how well the available data conforms to the expected formats, such as standardized nomenclature, as well as consistency, which is how well the values agree across data sets. So just as a reminder, we spoke in quite a bit more depth on these data quality dimensions on the last webinar, and I believe that the webinar would be accessible to review those if you would be interested. But if we take a second to pause here, we'd like to get a sense from the attendees today, which of these dimensions of data quality resonate the most with you and your organization. So we're going to ask you to enter your responses in the chat box, and I know that Melanie and Kay will be looking at the chat box, and during this presentation and during some of the question times, we're going to bring some of these up and raise any interesting points that we see. I'm just going to give a few seconds for people to enter into the chat box what they feel of these dimensions resonate the most. Then we're going to get right into the rest of the presentation. So if we look at some of the root causes of data quality, there are many root causes of data quality. There's a great book that I've referenced here, Journey to Data Quality, and I've extracted some of the root causes of data quality that resonate to me and we tend to see quite often in healthcare. And I think one of the first root causes of poor data quality actually is that we have multiple data sources. This is common in healthcare because we've got multiple source systems. These come from registration systems, labs, diagnostic imaging, and they all tend to store patients' data, such as demographics, birth date, etc. But each source system may have its own data validation rules and its own data format. So we actually might be running into the situation, and it's fairly common, is when you've got these multiple data sources, but they've got conflicting information. So it can be a challenge to determine which one is right and ultimately deciding how do we choose which data we select. And this comes down to validation rules and timeliness, how up to date is the data. We also see, unfortunately, subjective judgment in data production, and we want to be able to minimize the chances of the wrong interpretation of data or process information at the source of the data input, as well as during the analysis of data. And what we find sometimes is without clear documentation and without clear definitions of the data, so that both at the source or when people are entering information, if they don't understand what it is they're really entering or what they're trying to capture, as well as at the time of analysis, we may see that personal interpretations of that data may come into play and actually affect our ability to come up with meaningful analyses or interpretations of that data. We also see very often the security and accessibility trade-off, and this is in no way to minimize at all the importance of security and privacy of the information, but a lot of times, analytical folks and software developers and database folks, the way they are, is if they can't access information from one database, which may be the source of truth, they may actually go to other sources of data which may be less valid or may not have as much controls over the data, and it may be less valid. So we want to make sure that the information that we know is accurate, that is our highest quality data, is actually accessible to those who need to be able to access that. Another common issue that we see in healthcare is data that's coded differently across disciplines. So it may be across disciplines, maybe different source systems. And so we know that different source systems may code data using different coding schemes, ICD-9 versus ICD-10, for example, or other coding systems, or sometimes no coding system at all. And these differences actually hinder our ability to use the data, hinder the comparability and the compatibility of that data. And we see this sometimes even in our source systems where we have drop-downs that are not really codified, but it's free text. And so we might see, for example, weakness / symptoms of CVA as one of our triage codes, but then in an update of the triage document, they may replace the slash with an ampersand to represent and, or something along those lines. And so suddenly you've got in your data set two different codes which mean the same thing, but they're separated by, or they're different by a symbol. And so this can cause issues when we're trying to extract this data and analyze it and compare it. Another issue that we have with healthcare is complex data representation. So a lot of the workflows that we have in healthcare, I do a lot of work with the emergency program, and we're capturing fairly complex workflows with a relatively small number of drop-down menus, status codes, timestamps, etc. So we're trying to abstract the entire event of an emergency department patient's visit into a finite set of data. And so whenever we try to boil it down that way, we may run into issues where we're not able to actually adequately represent complexities of healthcare events or healthcare visits. Now in healthcare, we're also experiencing large volumes of data. These large volumes of data can come from electronic medical records, or as we talked about last time, even social media data, other sources of data which are giving our analysts a lot of information to access. But sometimes this large volume of data that we have may be too much of a good thing. So sometimes, for example, we may need to trim down the data that we're using because we have some limitations of our desktop analysis capabilities that were causing our stats program to crash because we've got too many records or too many fields. So somehow we trim out some of the data, and in that, if we're trimming out or we're not using some of the data that's at our disposal, it may impact our ability to come up with valid insights into the information. So we want to make sure that we're not, that we're not missing out on perhaps better sources of data, or picking and choosing things that may not be the most appropriate. And finally, changing data needs. And in project management, we would call this scope creep, or we always see, as we change processes on the front lines, as we try and do things differently, as we implement changes, sometimes the changes in patient flow or in workflows happen sooner than we can change our information systems to accurately collect that data. So we want to make sure that we're minimizing situations where the needs have evolved or the way the data is evolving, but we're still capturing data using the old rules or the old logic. So these are just some sample root causes of data that are fairly common in healthcare that I've seen and other people have told me that they've come across in their experience. And Melanie, I think you had a question at this point that you wanted me to address.
Thanks, Trevor. Well, I've been monitoring the chat a little bit, and it is interesting to see how well people are relating to the different categories. And I think we asked people to give us what their top issues were, and interestingly, we've had a few people say all of them, which is, I guess, not surprising to those of us who work with in this field a lot. Probably the most common themes that are coming across the chat here are accuracy and timeliness. And I think probably from my experience, the two probably go hand in hand a little bit. I've seen some comments here, and I know I've had some experiences too, where some of those accuracy issues seem to come from, I think, what you described, Trevor, about how the data is being recorded in the first place, and how consistent that is. And I think when we have a lot of that happening, it probably delays the timeliness of it, because it probably takes our data warehouse staff a little bit longer to get that into shape. So I don't really have a question, just sort of wanted to comment on what's coming in the chat, and I guess just to make the comment that we, being aware of these issues from a quality improvement perspective, we don't want them to hold us up too much, and I know, Trevor, you and I have talked quite a bit about that, about having this trade-off between wanting to have really good data but not perfect, as Durant would say, and getting it in a timely way. So I think that's probably what you're going to go into next, is some of the data, way that we can resolve some of those issues, but at the same time still have data that is usable for our purposes.
Yeah, thanks.
Oh, hi, Trevor. This is Kay here, and I'm just flagging that there's two questions that have come up on the chat, so thanks for that, Melanie. And Trevor, just wondering if you could take a moment to address Essie's question about what dimension of quality addresses loss of data quality as a result of poor data model design.
I think we're actually, if I can defer that one question, just because we do get into a bit of the data model design in the next session. We do bring that up. And so I would ask the person who asked that, if I don't address that adequately during that time, please feel free to raise the question again. And Kay, maybe if you can remind me, but we do get a little bit into the data model and how that impacts data quality in the next session.
Excellent, thank you. And then we also have a question from our Edwards around the quality effect of different collection techniques. So why don't we see if you're able to address it, but we can hold that to the end as well.
Okay, excellent. And I think this is great because, in my experience, the first steps in addressing data quality is understanding, all these different dimensions of data quality and knowing where along sort of that information chain from, entry into source system through to data being transferred from source systems into data warehouses and then into analytical databases and analytical software, being able to understand where, data quality can be affected, where we can improve data quality, and how it impacts our ability to analyze things is critical throughout that whole chain, or that whole chain. So we're going to talk about those in just sort of this next section here. So we're going to talk about how we can achieve high data quality. And I think what we would like to do now is, given that we've had so much great feedback on that first question, we're going to open it up again to people who are who are the participants to input into the chat box how you achieve high data quality within your healthcare organizations. And then we're going to go talk a little bit about the data quality management cycle in just a second. So what we're going to talk about today is the data quality management cycle, and there's really 5 components that we've put together for managing data quality within healthcare data sets. The 5 main components are define, validate, deploy, manage, and improve. And today we're going to talk about the first 3, which are highlighted in red. We're going to talk about the definition, the validation, and deployment of data. And in the next webinar, we're going to dive in a bit more detail in the manage and improve aspects. So when we start off, it's very important to have clear definitions of 2 key things. One is the context, and this context tells us what the quality and performance improvement goals and targets are, what our processes and workflows are, and the business rules. So basically, what it is that we want to do with this data, and this goes back to, once again, the definition of high data quality being data that is fit for use in their intended roles. And so we definitely have different data quality requirements if we're doing, if we're doing clinical research, where we need to, find definitive changes in a, control group versus a treatment group, for example, when we're doing clinical research, versus, if we're using data to spot trends in improvement. Are we, if we're changing processes, and are we trying to detect whether or not we've been able to improve patient flow, improve patient satisfaction, et cetera. And so knowing how we want to use the data gives us that sense of where we need to set the bar. And as we define the context, we also need to be able to define the data itself. And so this means that we need to have a clear understanding of what our source systems of data are. Where's the data coming from? Is it coming from your emergency system, from a scheduling system, from a surgery system? We need to have good data field definitions so that we have a common ground in terms of understanding the content that's going into these source systems, what type of data we have, the size of the data fields that we've got. And we talked a little bit about that in the last webinar in terms of data types, et cetera. And then validation rules. Validation rules are critical because we need to have validation rules on the front-end software so that we can prevent or avoid data that is inaccurate from being, or inaccurate or malformed or something that doesn't fit the validation rules from being input into the system in the first place. But then we also need to build in validation rules as that data flows through the chain from source systems into a data warehouse, into an analysis system, for example, so that we may have data validation rules as we analyze data so that we know whether or not a data field or a record is one that we want to include in our analysis, or if the data just is either missing or it's not, we can't be sure enough to be able to use it. So that's why we need to have these validation rules basically spanning the continuum of how data flows. This is how we envision that mapping of our data context and the data source systems and tying it into our performance indicators and strategic goals. So what I'm going to do is I'm going to start more in the middle here with our data. And this is the data that we would collect from our source systems. In this case, I'm using an emergency department example. But in this case, we would have, we know that we have data in our source systems. And we also want to align that data with aspects of our workflows. So we would need to know that this data that we have in this column here is part of the triage process. And in the registration process, we've captured this type of data, for example. And of course, in our data definitions, we would have a lot more detail in terms of the formatting of the data, et cetera. But this is just a demonstration to show that, you know, we have data and we need to be able to align that with the various processes. Along with our data, we would have the various validation rules. And the validation rules may be for each data element. For example, that our triage start date time needs to be, you know, before the triage end date time, for example, or that we need to have a chief complaint value that is stored as part of the triage document. So these are validation rules that hopefully we can build into our front-end system so that the data is clean going into the system, or at the very least, you know, include these validation rules at the end while we're doing the analysis so that we are not using faulty data in our analysis. So once we go back up to the process and workflow, then this is where we talk about some of the context. So the context is starting to be defined by the process, and then as we want to be able to evaluate our processes and our workflows and our quality, we assign indicators to various aspects of our performance, and ultimately we want to have our performance indicators tied to strategic goals. So if we take an example strategic goal here of we want 95% of our admitted ED patients to achieve a length of stay of less than 8 hours in the department, we can see that with this strategic goal or strategic indicator, usually these would break down into several sub-performance indicators. We're going to talk about this a little bit later, but I wanted to show this holistic picture at this point. Then our performance indicators then need to map to, you know, various aspects of our process. So we know that, you know, if some of the indicators that are related to our strategic goal of ED length of stay of less than 8 hours, you know, then our time to physician assessment, for example, that performance indicator would be aligned with this aspect of our process and workflow. So looking at things from this perspective then helps me as an analyst and helps me communicate with quality improvement professionals so that we can ensure that, you know, we're talking about the same things, that our data is in alignment with our workflows, and that, you know, we are all steering towards the same quality improvement objectives. Melanie, I think that you have a question at this point?
Yeah, I do. I mean, I'm always interested in seeing this, the way you map this out, Trevor, and I think it's a good example of how people can communicate and engage with each other to work to get better data for what they need. It makes me think that oftentimes as a manager or a leader in a department or a quality person, that we tend to not go through this process maybe as much as we should. In fact, I think a lot of times we just fire off an email to our performance reporting department or something and saying, I'm looking for the percent of patients that had length of stay less than 8 hours, and that's sort of the extent of the conversation that happens, and then we may or may not get something back. So I guess I'm just curious, in your experience, how do we go about having these conversations, and who would draw together this kind of map and have this conversation, and when and how should that happen?
That's a really great question. I think that's actually a topic for a whole series of webinars unto itself. But I think, if we were to look at something like a lean initiative that we may be seeing in a lot of healthcare organizations where they're looking at some aspect of patient flow or some aspect of quality. A lean initiative very often starts here, looking at mapping out the process and the workflows of the area that they're looking at. And so we would have fairly detailed value stream assessments of a particular workflow. The lean projects and Six Sigma projects typically will have performance indicators that are assigned to that, and so the strategic goals and performance indicators are very often discussed as part of lean projects. But then we would draw a solid line here where this arrow is, because in the data piece is typically, the domain of data analysts. And like you said, we'll see a data request coming in from a quality improvement team that says, I need this information, can you analyze that? And what I've found that's been very helpful on projects that I've been involved with and with my team is that we try and break this barrier down between the data folks and the process folks, and get the data folks working right with the lean team, lean project team right at the very beginning, so that data and validation and analysis is part of the conversation from the very beginning, so we can start thinking about all this stuff together, as opposed to having the data request more of an afterthought.
Right. Yeah, that's great. So it's the idea of having, when you're building a project team or a team for a new initiative, I guess it's the idea that right from the beginning, before you sort of even define what indicators might be useful for you, that you would have a data person right in that team right from the beginning.
Yeah, absolutely. Whenever feasible, I try and ensure that we get our data people involved in the projects right at the outset.
Yeah, I think that is really good practice, and I think oftentimes we involve them just a little bit too late. We've sort of made some decisions that we're kind of then wed to just a little bit before we bring them in. So I think that's a good lesson about bringing them in right from the beginning. And I think that in my experience, the data analysts are becoming more used to those requests also, whereas even maybe 5 years ago, they wouldn't feel that it was appropriate for them to be at a meeting or a project team meeting right from the beginning. But now I think that we're understanding more and more each other's roles and how we can facilitate better work if everyone's there from the beginning.
Totally agree. And just to add one more point to that is that we're seeing a lot more traditional data analysts having at least some level of lean or Six Sigma training, so they can interact very well with the quality teams.
Good point.
So if we carry on then to the next section of the data quality management cycle, we're going to talk about validate for a second. And so just as we use indicators and metrics to validate our performance and our quality, we also want to identify appropriate data quality metrics that we can use as we scan and profile our data to be able to compare our ongoing data quality metrics against baseline performance and actually set targets. If we know that we have some bad data, we would treat the data quality improvement project like almost any other improvement project, where we try to identify root cause and develop some interventions to be able to improve the data quality. And I'm sort of getting ahead of myself here talking about the last two phases of the cycle, but that's ultimately where we're going by having well-defined, valid data quality metrics. So when we're defining data quality metrics, generally there's two types of metrics. We would have generic metrics which tell us, we can apply to all columns. For example, how many records do we have in a table, or how many columns are in a table, how big is the database, and those are overall metrics that give us a bit of a structural sense of what our data looks like. But then if we delve more into specific data quality metrics, then these would be specific metrics that we would apply to a column or combinations of columns, for example, that we use to sort of, wherever possible, quantify some aspect of data quality. And this would be, for example, if we have a data field, it would be, what's the number of valid values in a table, or what's the percentage of valid data that we've got for a particular field. But if we want to develop metrics, there's a few things that we need to consider. And some of the things we need to look at is the effective data quality metrics should be insensitive to the size of your database, to your data warehouse. So we don't want some indication of validity or something else to change just because you've got more records. So the effective data quality metrics need to be insensitive to sort of those structural components of your database. They need to accurately reflect the degree to which the data meets the associated need, and this once again goes back to the Duran definition of data quality, being associated with a specific need. Data quality metrics need to be independent of each other, so we're not duplicating the measurement of the same effect, for example, as well as we need to keep our data quality metrics to a reasonable number, so that just like any other metric that we've got for healthcare improvement, if we have too many metrics, they tend to get watered down, or they may be confusing to remember what each one of these metrics means. So what we've got here then is a set of data quality categories that we can use to define some of our metrics. So keep in mind that when we've got this type of data, the data quality categories, each one of these categories may not apply specifically to each and every data field that you've got in your database, but it's important to be aware what these data quality categories are. So for example, if we look at data quality category of valid, this means that if a field is valid, it means that the data passes all edits for acceptability. And this could be, for example, that the medical record or identifier number is formatted properly. And we see this in, health insurance numbers that have spaces, after every 3 digits, for example, or not, or dashes in there. And, if the accepted format is to have none of those in, we want to make sure that, we are having validly entered data. Another category that we can use for measuring our data quality is completeness. And aspects of this are that the data element is, number 1, always required, or number 2, required based on the condition of another data element. And this would be, for example, an option of always being required would be a patient identifier. So we always need to be able to identify which record a patient belongs with. Whereas an ambulance EMS run number will only be required if the patient has arrived by ambulance. If we look at consistency, this is that the data element is free from variation and contradiction based on the condition of another data element. So this would be looking at things like the physician initial assessment timestamp is always after the registration and triage timestamps. Uniqueness is the data element unique, no duplicate values, and this would be in our patient database that each patient has a unique identifier in it. For example, we do not want to have any duplicate identifiers. Timeliness is an aspect that the data element represents the most current information that we have about a particular workflow or information about a patient, for example. And the next two are accurate and precise as data qualities. And accurate means, is the data element, are the data element values properly assigned? And precise is that the data element is used only for its intended purpose. So if we look at accurate, this would be the degree to which timestamps for events reflect actual values. So if we have a time of discharge, for example, is that actually, how accurate is that? Is this, an accurate representation of the time that the patient was discharged? If we look at precise, this may mean we run into areas where we might have an imprecise definition, so that it may be that the discharge timestamp reflects the time the patient left the department, if it's defined that way, and not some other related timestamp, such as the time of disposition decision. So this is where we get back into source information, data being input in the source, is that we may get very accurate data of somebody entering, the time that the doctor decided that the patient can go home. But if that, so if that could be totally accurate, but if we're actually supposed to be recording the time the patient physically left the emergency department, then it means that it's not very precise. That's sort of how this accurate and precise differ. And so if you wanted to have a basic template in terms of how we can look at data quality. I've got a sample here. This was something that my shop is starting to work on in terms of being able to capture data quality. But I'm not going to go through each one of these fields. It's really important to notice that we would have in this type of report, we would have the data elements that are of interest. We've got the data quality categories, so valid, complete, etc. And then wherever possible, if we can develop a computer code or algorithm to go through and measure, the percentage of records that meet that data quality category, then we can put in, a quantitative measure. So, for example, in this case, all the data that we have is validated at source, for example, and so it's valid in our database. But then we have, for example, only 97.3% of our records would have a triage start date, and these types of qualitative values are possible to develop, with your analytical tools, with your reporting tools, by building them into whatever system you've got. But it's important to know that not all data quality categories are relevant. So we may not have, if unique is not relevant, for example, we don't need to record that for each data element. And as well as something like, I want to mention too, that sometimes these things are hard to estimate. So we may not be able to come up with a quantifiable measure of accuracy or precision, for example, but we may have a gut feeling in terms of, is something accurate or precise. And so what we can do is we can go with more of a qualitative measure. So in this case, I've just put green for, that we're pretty sure about the accuracy. Yellow is something we need to be a little bit more concerned about. We are not able to quantify that yet. And then the red would be something that we know is a problem area and we're working on it. So the take-home message from the data quality report would be basically, quantify it where you can, but don't limit yourself to only quantifying it. If you have, estimates or you want to be able to just get a sense of how the data quality is with these various categories, by all means put in, some estimation, whether it's color-coded or, high, medium, low, etc. The whole point is just to be able to communicate, sort of these aspects of your data. Melanie, do you have a question at this point?
This data quality report that you've shown has generated a bit of interest, and I'm thinking it's such a great display of how we always talk about using data to drive decisions. This is very much using data about your data, I think, to drive your decisions about what you're going to do with it. So I think this is where I kind of ask my million-dollar question that I always ask is, so we know that the data is not perfect. Let's say in this example, your discharge diagnosis seems to have some issues a little bit. It's not perfect in terms of validity. It's not fully complete. It might not be the most up-to-date. So it's kind of seems like it has some precision problems. So it's probably not great. At the same time, let's say I am running a fairly large quality improvement project, and it sort of relies on me understanding the patients who are coming back from the hospital with a specific discharge diagnosis. So at the end of the day, I kind of need to know this. So what are we going to do? So the data is not perfect, but at the same time, we're running this project, and we need to have a sense of whether we're making improvements. So back to you then, the million-dollar question: how do we use this information to decide? Okay, well, what are we going to do? Can I have the data? Can I not have the data? How is it going to affect my results? I guess is another thing I'm interested in. And a related question, Aaron has also asked: is there a way to display back to users what the effect of some of those data quality issues might be?
Yeah, absolutely. And so typically, if I'm working with data and I know that we've got, say, some accuracy issues with some timestamps, particularly when we're looking at time intervals, for example. One of the clearest ways to communicate that back to users, particularly when you're doing data aggregation, for example, would be to include error bars on your graphs, for example, so that you can get a sense of the range of what the intervals might be reporting. Another way that we would look at data we would use box and whisker plots anyway, but when you're looking at box and whisker plots or other ways to measure a sense of the variability in the data and identify where outliers exist, it gives you a sense of maybe more of a range. And so when we're talking about when we're communicating data, especially data, like I said, which maybe have some of these issues, is I talk more about ranges of data. So I would never just say the median or the average interval for this process is 2 hours, for example. What I'll always try and do is say, give it some sense of variability, whether it's a standard deviation or a standard error of the data, or mention some outliers we have, do a histogram or a density plot where we can see where our information is clustered and see where we're having some outliers, or like I said, add error bars to box plots to bar charts and line graphs and stuff. But like I said, this is where the conversation has to happen in terms of communicating with the quality improvement people and saying, this is where we know where the errors are. This is what we can provide you. What are you using it for? And find that middle ground. So how can we communicate? How can we come up with valid interpretations of that data or using that data in such a way? So, for example, if we have a lot of missing discharge diagnoses, we can analyze the ones that we have, report on that, and then we would just need to say, in the analysis, the description of the results, for example, we would just say that, 25% of our visits did not have a valid discharge diagnosis, but out of the ones that we were able to use, this is how the distribution was. And then what you try and do is rule out any systematic bias, for example. So if we're, are we missing 25% of our discharge dispositions just because, across the board we're missing them, or is it because there's some particular physician who's not putting in discharge diagnosis, or is it because, we're missing, or a system error? Is the system, for example, rejecting, the input of a certain type of discharge diagnosis? So if we have some sort of systematic reason for this data quality error, that would be more concerning than, say, just random error scattered across the board.
Thanks so much, Trevor, for that. And I'm just keeping my eye on time as well. We do have one question from Marie-France en français, and she asked at what frequency should you do this analysis and its continued collection? So just maybe briefly on that, if you have any insight.
Yeah, I would say that, it all depends on how you're using the data. I would certainly try to, before undertaking a major project, run a more, a complete data quality profile so that you can go into the project knowing what your data quality situation is. I also know that, when we experience a major change to our data warehouse or the way the data is being transferred, sometimes in the past we've experienced a change in data, and so we would run a profile, before and after, a major change to our database system, just to ensure that, the change in the database hasn't impacted data quality in some way or introduced some errors. Hopefully, you're introducing changes to the data quality or into the databases to actually help enhance data quality. And then finally, what we're trying to do is build in our data quality reporting to most of our ongoing regular reporting. So if we have, a dashboard that goes out on or a report that goes out, one of my goals is to be able to actually include a snippet of data quality relating to the key metrics that we're reporting, so that, we actually always keep the quality of the data front and center, so that we can always sort of be aware of how that might impact what the actual report is telling us.
Excellent, thank you.
Okay, I think I'm going to move on a little bit, just because I know that we're getting close to the end of the session today, but I did want to talk a little bit about the deployment phase. And we said we do not want to achieve, or we cannot achieve perfect data quality. We need to work on, continually improving healthcare and using the data that we have. But when we're deploying projects, high-quality data needs, when we want to ensure that we have high-quality data, we need to know how is that data being used. So what are the stakeholders' needs? How are they going to be using the data? Can we have use cases, for example, that describe, the reports they want to run? It goes back to the discussion about, the data quality, the data people and the quality improvement people is, have that discussion and understand how and why data is being used. Then we can look at the data preparation and processing requirements. So how does our data extraction, transformation, and load procedures from source systems to the data warehouse, for example, how can that either improve data quality by fixing errors, or how can it hinder data quality? And then looking at the data availability and usability. So how is the data accessed? What systems and tools are we using? Are we forcing people to write queries directly to source systems and pulling the information out that way, or do we have a more robust system in place where data is already pre-processed, validated, and much less prone to error? And we also need to know which processes and outcomes are being measured, and are they being measured in the right ways. This requires us to build in measurements and metrics that are appropriate for the types of projects that we're undertaking. And this sort of goes back to our earlier slide about being able to align our metrics and indicators with our strategic goals of healthcare improvement, for example. I'm going to just briefly skip that slide, but going into this one about choosing appropriate indicators, so much about data quality is about how we use the data and how we present the data, and ensuring that the insights can be valid. And so indicators are metrics that are more useful for driving business decisions because the indicators have this context assigned to them, and this context is what separates an indicator from a metric, because when we're looking at the indicators, we usually include an acceptable range and a target for these indicators. And indicators we use to identify whether current performance is good or bad, for example, how far away we are from reaching our performance targets, and they also tell us how performance is trending. And this goes back to the earlier comment then about if we have indicators on what our current performance is, if we can introduce things like error bars or some sort of way to get a sense of the range or variability in the data, then that can tell us that, rather than, just reporting an average or a median score, for example, we can report some sense of variability in the data or a range so that, decision makers have a much better sense of what is going on with the data, as opposed to just having a single number or a single value. And so then the indicators that we develop help us align between this executive management and operational levels of healthcare. We talked about this a little bit before, where we would have the tactical level indicators that are useful on the front lines for improving a process, changing workflows, etc. But ultimately, the activities that we're measuring, the things that we're trying to improve, need to roll up into some strategic level goals, so that as an organization we're able to advance our overall healthcare improvement activities. And so we've used this acronym called SMART indicators. And when we're developing SMART indicators, we know that indicators need to be specific, measurable, actionable, relevant, and timely. So once again, it sort of ties back into data quality by there being sort of multiple dimensions that we need to be aware of when we're looking at data, and particularly when we're analyzing data and choosing how to report data to decision makers. And so the bottom line, I guess, that I wanted everyone to take away from this particular slide is that so much about data quality, once again, actually is how we intend to use the data and report on it. So the next session, we're going to talk about the manage and improvement components of the data quality management cycle. And what I would like to do is turn it over to Melanie and Kay at this point for any further questions or reflections.
Thanks very much, Trevor. That was great. There were two outstanding questions before we get into wrap-up. I just wanted to go back to R. Edwards' question. That was around any of the quality effects of different collection techniques, for instance, collecting race or ethnicity data as part of face-to-face hospital registration versus using e-tablets. So that was one. And then the second brief question was from Aaron Lynn of whether it's possible to share the code that was used to generate the report.
Yeah, absolutely. First of all, I think the report is itself, the report template is available for download. I can talk about how I came up with those values. The code would be fairly specific to, the data set that we're working with, but, certainly I'm open to someone sending me an email about asking for this, and I'd be happy to share some ideas and share what I can. In terms of the different data collection methods, yeah, different data collection systems have some benefits and drawbacks, and I think that the key thing that when we're looking at information that is captured is the ability to validate on the front end. So the more that we can validate information on the front end coming in, so whether data is data that's required, if it's a mandatory field on your system, I don't think it matters if it's on an ADT system or Tableau or whatever. If we can develop systems that have strong validation rules, so if data is required that, we can't proceed without entering it, or at least, remind the user this information is required. So that's one thing, and then making sure that the data is properly formatted in the source system, because if we could get the source systems, no matter what it is, to be validating data and ensuring that garbage, or that the data going in isn't garbage, we have to do a lot less on the back end to clean the data, to fix it. So like this whole thing about garbage in, garbage out is so true when we're talking about data quality, and if we can minimize junk going in, it makes our data at the back end so much cleaner to work with.
Excellent. Thank you so much, Trevor. Well, just before we end today, I wanted to invite all participants on today's call to our next call in this Data Bootcamp series titled Effective Data Quality Management. And it will be taking place in the new year on January 14th from 12 to 1 p.m. Eastern Standard Time, where both Trevor and Melanie will be back to build on today's discussion. You'll also see on the screen a link to some of CFHI's upcoming free on-call sessions that are being offered between now and the end of the year. And we encourage you to take a look on our website for the full list of sessions and registrations. Also, Sheena's just letting you know through the chat, but yes, the PowerPoint and the materials, including that table that Trevor shared, will be available to all participants today. So right now, I would just like to thank both Trevor and Melanie for your excellent presentations today, and for Kelly and Sheena working behind the scenes to make this webinar happen. If you could please take a moment to fill out our webinar survey, which will appear on your screen momentarily, that would be greatly appreciated. You should see it now. We want to thank everyone for your attendance today. We look forward to hearing from you in January, and this officially concludes today's session. Have a great rest of the week.
Thank you. Ladies and gentlemen, this does conclude your conference call for today. We thank you for your participation. You may now disconnect your lines and have a great day.